Mr. Griffith, 5 minutes for questions, please.
Thank you very much, Mr. Chairman. Mr. Clancy, I'm going to ask you a couple of questions. You mentioned that community pharmacists have little negotiating power when it comes to contract provisions set by the pharmacy benefit manager, and we've seen that, the PBMs, we've seen that before. Can you explain how smaller and rural community pharmacies are disproportionately affected by this inability to effectively negotiate, and how that can, in turn, negatively impact patients?
Yes. And our pharmacies, most of our pharmacies are in rural Georgia, and like, for example, one of our pharmacies, 25% of our business is through one PBM. And if they change their reimbursement model or whatever, it impacts us in a great way. And so the lack of getting on that contract or not getting on that contract depends on whether we as a business survive. One of the concerns in Georgia is we have 4 counties now that have no community pharmacies because of some of this that they're dealing with.
And not just that, but can it affect the patients as well? So I have, and I know the committee's tired of hearing about Clintwood and Hayside, but if you look at them on a map, they look like they're only about 5 or 10 miles, maybe 12 miles apart, but there's a big mountain in between them. And the mayor of Hayside told me one time it takes him an hour. He always plans on an hour to get to any of the meetings he has to have in the county seat of Clintwood. So if you're the community pharmacy in Hayside and the PBM takes you off, that patient's now going to have to drive to Clintwood to get their drugs and to rely on somebody because most of us rely on our pharmacists, our community pharmacists. Is that not also a problem?
That is, and CVS Caremark being the PBM, many times they require their patients to go to one of their pharmacies. And in rural Georgia, there's not a CVS in every community or county. And so it compromises them with access.
Yes, sir, I understand that. Beyond drug pricing disclosures, what are some of the other impacts that gag clauses have on the pharmacist-patient relationship? Can you think of any? Because I can think of one. A constituent came to me, and we were just talking about this whole gag issue, and she'd stumbled across it, and at first she had questions about her pharmacist because originally it wasn't considered a part of the formulary. So she had to pay cash for it. It cost her $17. And as Chairman Walden said in his opening statement, then they notified her it was in her formulary, and she called in her prescription, and they told her she'd have to pay the copay of $50. So she called her pharmacist all upset, thinking that he was doing something goofy, and doesn't that damage that relationship? And he explained to her that he wasn't allowed to tell her that, but since she'd found out about it, she could pay the cash if she wanted to.
Oh, definitely. And there's some times where the patient's required to get the brand instead of the generic, which is a cheaper copay. And I think it's just through rebates or some sort of agreements that they've worked out. And so that impacts them as well.
Attorney General Schmidt, I have some theories. I like listening to the testimony and listening to folks, and you did a great job, and you've got some great people signing onto these letters. But one of the concerns that I might have if we have, and there's an answer to it, but it's going to take money and effort. If you've got somebody who's skilled at determining financial fraud, they might go into the home. Let's say the fictional characters from Seinfeld, George Costanza's parents, who were always fighting with one another. Now, if one of them was the patient, somebody who's a financial investigator might automatically assume that there's some kind of abuse going on there, and they've been having that relationship that way for, as the fictional characters pointed, 50 years or so. And so aren't you going to have to train folks to be able to distinguish between, financial fraud is different than physical or mental abuse. And there's a concern, and it gets complicated, because I actually had a case one time where they thought the parents were doing something to an infant. And I know this is a little bit different, but the infant was failing to thrive whenever it was in the parent's home. We ultimately discovered the infant was allergic to dogs, and they had a dog in the house. So every time they'd put it in the aunt's house, the child would do better. They'd put it back in the parent's house, the child would fail to thrive. So there's a lot of complications with it, and I think that your financial investigators are going to have to be trained if we give them this authority, and somebody's going to have to pay for that training, or else we're going to have people bring in cases that maybe they ought not. And one of my concerns there is that when you bring a case, particularly against a family member, you're yanking that family apart and you're pulling that person out, and you really have to walk with care. And
right.
What do you say about that?
Right. Representative, certainly speaking for myself, I'd be very sensitive to that concern. We see those types of dynamics, not just in the context of our Medicaid fraud work, but in the context of our broader criminal work for the state. So we are accustomed to dealing with those sorts of distinctions, and we're human, and sometimes we get it right and sometimes we don't, but I believe we do in most cases. I would say one thing. I can't speak for every state. Perhaps the larger states with larger Medicaid fraud control units do have distinct financial crimes investigators versus patient abuse investigators. For Kansas, and I think for most of the small and mid-sized states, we do not. We do have dedicated fiscal analysts who are the number crunchers that don't go out and do field investigations, so they're purely financial. But with respect to our investigators, in our Mafuku, we have 6 sworn law enforcement officers. They are all cross-trained. They handle physical abuse, sexual abuse, financial abuse, as well as fraud. And the reason for that under current law is that they are doing those abuse cases when they occur in a healthcare facility. So they already have the skills, they just can't apply them in the non-institutional setting.
All right, I appreciate that. Yield back.
Sure, thanks, gentlemen. Gentlemen, yields